Thank you, Anita. Thanks to the organisers for asking me to speak today. And I should actually, for those of you who are here this morning, unintended omission, Richard Levy was supposed to give that TAVI talk this morning. He leads our TAVI programme at Wythenshawe and wasn't able to make it today, so thanks for letting me step in. So, pushing the boundaries, MitraClip intervention, MitraClip implantation. What I'd like to do first is just set the scene and outline some basic principles which don't apply just to MitraClip but to transcatheter mitral intervention generally. I was at the mitral valve repair lunchbox session today, which was superb from an interventionist perspective, listening to two leading mitral valve surgeons talking about their experience, the evolution of practice and lessons learned. And really, they could everything they spoke about today applies to what I'm going to refer to in terms of mitral valve intervention. There's some key principles that we need to bear in mind. Anita's already taken you through some of the echo aspects of this procedure. She pointed out it really is an echo-dominated intervention. I'm going to try and look at the data to help give some understanding about how we should be selecting patients, still an area that's far from clear, I think, for MitraClip intervention, and then just tie up with some summary and concluding remarks. So, innovation in medicine, we all understand how surgical interventions have been evolving to minimal invasive and now transcatheter approaches with the view to improve quality of care whilst maintaining an efficient and cost-effective therapeutic intervention. And this often leads to a shift in paradigm in terms of our understanding of how diseases are treated, and we're seeing this with transcatheter therapies in particular. We're having to examine our values and our expectations in terms of how we treat an aging demographic. We've had a talk today about the health economic aspects which are relevant as far as all these transcatheter interventions are concerned, and they certainly demand of us a new level of collaboration. And transcatheter interventions for mitral regurgitation exemplify all these issues very well. Mitral regurgitation, you all know the statistics about this, increasing prevalence with age. We find mitral regurgitation is common in heart failure patients. There's debate still about whether MR is in these patients is simply an indicator of poor LV function, or is it in fact an independent risk factor for poor outcome. But we do have data which shows that heart failure patients with MR do worse off. And MR does appear to be a risk factor for heart failure in post-MI patients, and the mortality data for severe MR is high. Not only that, but there's significant morbidity implications, and these patients do place quite a burden on the healthcare. And 60% of the costs incurred are through repeat hospitalisation. Anita mentioned this also, very well. Transcatheter interventions for MR compared to TAVI it's a completely different beast, and this, in many ways, summarises why. There is no, as you know, there's no one cause, there is no one mechanism, there is no one approach fits all therapy to treat mitral regurgitation. And this is reflected in surgical intervention for MR, as you know. Degenerative MR is pretty straightforward in terms of understanding the indications for surgical intervention. Secondary mitral regurgitation and your ischemic and functional MR is a different group altogether. And in this group, it's highly controversial as to the role of surgery. Medical therapy is certainly the first line of treatment, and what data there are for the role of surgical intervention suggests certainly no mortality benefit, and it's debatable what level of clinical improvement one might gain. And this certainly reflects the underlying ventricular nature of the problem as well as the patient characteristics. That said, we know that patients, and this is Euro Heart Survey from a few years ago, out of patients who do satisfy criteria for surgical intervention, a large proportion do not receive surgery. And there are a number of reasons for this, which I've already alluded to. We are talking about quite a diverse population, a group often with advanced comorbidities. There are often controversial aspects of surgical treatment, and where mitral valve surgical repair is indicated, there may not be access to the expertise. So on the back of all this, there's a recognition that there's an unmet clinical need, both in terms of patients who are high risk but would otherwise be suitable for surgical intervention, as well as that heart failure group of patients who typically do not receive any surgery, who are treated medically, who may benefit from transcatheter approaches. And so MitraClip and indeed all transcatheter mitral interventions are seeking to try and meet that unmet need by reducing the MR and hopefully reducing the morbidity. So by the same token then, we're going to have quite a few challenges in developing effective transcatheter technique, very heterogeneous population with complex functional anatomy and, as I've said, diverse mechanisms. And this shows how a lot of work has been invested in developing transcatheter approaches, but just how difficult it is to get it to the point of commercial use. And as you're aware, at present we have just one device, the MitraClip device, which is commercially available and which has been subject to the pivotal randomised trial. Adding to the difficulties when assessing these therapies is the other challenges in terms of clinical trial methodology. So comparing percutaneous techniques with surgical techniques have their own inherent flaws. The role of surgery varies according to the etiology mechanism of MR, and indeed there is some paucity of data in certain MR groups as well. What we have learnt, what we do know, and these are some basic principles that I referred to at the beginning, is that to succeed in terms of delivering effective transcatheter valve therapy, we have to ensure we select our patients well. And we have to show good attention to detail. The multidisciplinary approach has been discussed in the context of TAVI this morning. It applies equally for mitral interventions, and we have to assess our outcomes in detail. From the interventionist perspective, certainly it demands a good understanding of functional anatomy, more so, I say, than we would normally be trained to develop. Detailed clinical assessment and new techniques, which these techniques are quite different for us as interventionists, and the temperament required is quite different for us, not your typical interventionist procedure by any stretch. And in trying to select the right patient and assess them appropriately, the multidisciplinary team does not just involve those involved in the cath lab at the time of the procedure, but certainly our surgical colleagues, our heart failure colleagues, from whom we have a lot to learn in terms of assessing patient outcomes, as well as primary care, heart failure, nurse specialists, and of course our anaesthetists. Selecting the right patient for MitraClip involves looking at a combination of clinical and anatomical factors, and it's evident to you that the decision-making will obviously be different in degenerative and functional MR patients. Heart failure trials and heart failure specialists do have a lot to offer us in terms of optimizing our approach as interventionists or surgeons who are delivering this therapy and assessing outcomes. And what is certainly required, and it's obvious, I think Anita will attest to this as well, compared to our TAVI patients, is a far more exhaustive process in trying to understand which patients will benefit from therapy and which patients won't. And what is required is a combination of clinical functional echocardiographic assessments, the use of biomarkers, which not only helps us understand which patients to select, but helps us understand how effective our intervention has been. And hopefully we can then look at the non-responders and determine what factors lead to success. And of course, general points which you're all aware of. Your therapy is only designed to treat the valve problem to hand. These patients do have advanced comorbidities, and like surgical interventions and any other valve intervention, you have to consider the systemic issues which might limit the clinical benefits to be gained. Risk scores, as we've heard, are imperfect. They weren't designed for valve disease patients. And the frailty index is something that's been described more and more as we see the evolution of these transcatheter approaches. So the MitraClip specifically, as you know, it seeks to replicate the Alfieri stitch. So instead of a stitch, we have a catheter-based system with a cobalt, chromium and Dacron clip at the end, and it was designed primarily for degenerative MR, but it has evolved in terms of how it's been applied. And it consists of a catheter, a steerable guide catheter that you see here, clip delivery system that you advance. It's a transeptal puncture technique, as you know, so we go via the femoral venous approach. That's the clip at the end. And the advantages of this device are that it's repositionable. It permits real-time assessment of your MR reduction. And as I say, it's now being applied in selected patients with degenerative and functional MR. What is absolutely clear is that imaging cannot be emphasized enough regarding, with respect to delivery of this therapy successfully. And we're certainly calling on new standards, I think, from our echocardiographers when we're delivering mitral intervention therapy. It's obvious, and again, the lunchtime session today really highlighted this, how all these transcatheter techniques are crude. They fall short of the direct surgical visualization you have when you are repairing the valves. So we have to do as much as we can to give us as much information as possible. So now not only do we have to ask the echocardiographer, do we want to know, is it just P2 prolapse, but we want more information about the nature of that valve, the nature of the abnormality, and whether we can, whether this device is actually going to provide an adequate repair. Pre-procedurally, MR and CT, there are dramatic advancements in imaging which will permit enhanced evaluation both anatomically and functionally. 3D TOE has, it's certainly at the inception of MitraClip therapy, this was very much 2D echo-led, 3D developed later on. I think where it's in a situation now where most of us would say 3D TOE is mandatory if you're going to deliver MitraClip therapy. If we look at the clinical development of MitraClip worldwide then, it received CE mark in 2008 and almost 5,000 patients have now been treated, and the clinical evidence has been accrued through the randomized controlled trial, the EVEREST II trial, as well as registries based in Europe. I'm going to take you through the data and then make some points really about what patient selection based on that data. So the EVEREST II randomized controlled trial was designed to take patients with significant MR who had preserved LV function and they were randomized to MitraClip therapy or surgery. Both degenerative and functional MR patients, they were randomized in a 2-to-1 fashion, and they had very rigorous anatomical criteria that had to be satisfied, which I'll come to shortly. And the efficacy and safety results certainly suggested that whilst the MR reduction was not as effective as surgery, it did lead to meaningful clinical benefits. There were lower major adverse event rates, an improvement in functional class, and certainly evidence of improvement in LV remodeling also. These are the eligibility criteria that Anita also showed. So much more rigorous, as I'll come to, than the registry data that patients treated in Europe. And this is just demonstrating echocardiographically what we're looking for when we're assessing for coaptation length and depth in the case of your functional MRs and flail gap. So I thought I'd give an example of an EVEREST II trial patient. This patient I treated, 48-year-old, NYHA23 symptoms, myxomatous mitral valve with flail P2, prolapse and flail of the P2, and resultant significant MR with preserved LV function. And hopefully this will work for you. So you can see grossly abnormal valve there with severe MR. And this is just an example of 3D TOE and how it gives us a surgical view, much better appreciation of the anatomy. So it's just an opportunity again to go through the MitraClip procedure with you. The transeptal, as Anita mentioned, is quite different to transeptals that are performed by electrophysiologists. So the concept of a targeted transeptal is one that has emerged with our structural interventions. And this is to ensure that the device can be delivered and maneuvered effectively with ease. And what we do is we take a mid-fossa and quite a posterior transeptal approach. And we have to assess also, not sure if this will work, but the length and the coaptation to ensure that we have enough height. We advance the steerable guide catheter following the transeptal into the left atrium, and you can see the clip delivery system here advance beyond the guide catheter. There are some key views that we use, and a systematic approach is important in making sure that the clip is positioned with a straight trajectory so that it splits the MR jet. And so a lot of effort has to be placed in making sure that you have axial alignment and adequate splitting of the jet. And again, 3D echo is extremely valuable when assessing for clip orientation. Once we're happy with our approach, the clip is advanced into the left ventricle, and at the bottom right you can see grasping of the leaflets here. So the clip is from the left ventricle brought up, allow the leaflets just to flop into the arms, and then we tighten. So in this case, we initially placed one clip, and as you'll see, there has been a reduction, but there's still a significant medial jet, and so a second clip was placed, and that resulted in a very nice reduction in MR. And this patient was followed out to 2 years and has got just mild MR. And this is the classical double orifice appearance that we see on 3D echo with that tissue bridge. Patients are hemodynamically assessed, and it's been very interesting to see that we observe immediate improvement in quite a large proportion of cases. So we do pre-procedural right heart pressures and cardiac output measurements, and this cardiac output went from 2.2 to 4.5 following clip placement. It's also important in terms of the complementary nature with echocardiography when assessing whether a second clip would be appropriate. To date, as long as the criteria are met and we don't put 2 clips in where there's a concern regarding the mitral valve orifice, there haven't been any reports of mitral stenosis. Clearly, in borderline cases, the usefulness of hemodynamic assessment along with echo assessment should be taken advantage of. So that's a young degenerative MR patient, but the UK patient falls into a completely different group, your average UK patient, and that's the group I mentioned at the beginning. Heart failure patients who have MR, who we know do poorly with their MR, are not treated with surgery, treated medically, come into hospital repeatedly, place quite a burden on the healthcare system. And we've seen, as this therapy has been applied in the high-risk registry of the EVEREST study, but also the registry in Europe, that there are potential benefits to be had in this group also. And what is quite notable is the difference in the patient groups treated in the randomised trial, which are predominantly degenerative MR, and the registry studies, which are functional MR. And the functional MR patients, as one would expect, are higher age, have more advanced comorbidities, higher surgical risk patients. And these, I'm not going to, I'm going to run through these pretty quickly and just give you the basic sort of snapshots in terms of data and the take-home messages. Once again, we do see a reduction of MR in these patients with clinical benefit. Observe a reduction in rate of hospitalization, improvement in functional class, and as I mentioned earlier, we have also observed improvements in LV remodeling. The Access EU study looked at MitraClip patients, following them up, largely functional MR patients. Once again, reduction in MR, low safe procedure, improvement in their NYHA class, and other functional parameters. And we've had, there are about 3 or 4 now registries of relatively small groups still, which reflect the same findings. And this study by Franson et al. Was actually of patients at end-stage heart failure, which also showed benefit. This was a very small group that was, the results of which were presented last year, which looked at non-responders to CRT, suggesting there may well be a subgroup that might benefit. And tantalizingly, from the health economist point of view, we have seen in this data reduction in heart failure hospitalization. So clearly the implications are quite significant if we're able to deliver therapy to offer this sort of benefit. To put all that together then, I thought I'll summarize those findings, then we can talk about how that applies to current practice, or should apply to current practice. MitraClip then, as we've seen, has been applied to quite a spectrum of pathologies. The approach taken in all of them is a final common pathway of creating a double orifice valve. The clip can be used to approximate the leaflet at different locations, and more than one clip can be used. Whereas the EVEREST trial looked very specifically and kept rigidly to central coaptation problems and central MR jets, we have seen in the registry data more complex group of patients, patients which don't necessarily fall into the anatomical group, which will have depressed LV function, where the coaptation length, depth, flail gap falls outside those criteria, and they have shown response to treatment. So I think what we can say thus far is it certainly appears to be safe. The EVEREST anatomical criteria were rigorously defined and did demonstrate benefit in mainly degenerative MR patients. I think the European experience certainly provides a proof of principle for more complex group of patients. What it does is, I think it's provided a signal and is really hypothesis generating for the role of this sort of therapy in functional MR. Clearly, it's early days. We don't know about the long-term durability. In a high-risk population, one can argue that the safety advantage might outweigh that durability issue, but at which point that balance changes, where it becomes equivalent, or indeed where it favours surgery or just medical therapy, we don't know. And the limitations in terms of understanding and interpreting the data are hampered by the fact that you can't easily extrapolate your surgical literature to your MitraClip data. So we can't say based on surgical data whether our post-MitraClip patient with +2 MR will do worse off than +1 MR. The data thus far suggests they both do well. They both have improvements in their LV remodeling. But clearly, we do require more assessment of of this therapy in that group of patients. And of course, whilst the early data is very encouraging, there is quite appropriately debate about the role of concomitant annuloplasty in these patients if we are to learn from surgical practices and if we're going to apply this to diverse pathologies. So at present, certainly MitraClip appears to have a complementary role to surgery in patients who are too high risk for surgery but have clearly favourable anatomy. The functional group, the registry data would certainly suggest there's a benefit to be had in a subgroup of patients. There's no doubt that further randomised data is required, and this is something that is going to be the subject of a randomised study. And who knows, what would be nice would be to develop some sort of a patient selection criteria table which can help guide us in terms of which patients are best treated with surgery, which patients fall into the MitraClip group, and indeed which patients are past the point of benefiting from intervention and should just be treated medically. But there's no doubt that this is a simplification, and we do see patients, as we heard earlier on today, who functional MR patients who one would not have thought would have responded to surgery and did so. And that really emphasises to me how complex this problem is and how challenging it is to actually identify the group of patients that will clinically benefit. So to conclude, safe, feasible, certainly very promising early results. At present, the target population is confined to a high surgical risk population with degenerative MR and a subgroup of functional MR patients with reduced ejection fraction. There's certainly lots of unanswered questions and a clear recognition that this is an evolutionary process. It's a first-generation device which will need to be refined. The role needs to be defined more clearly. And there's no doubt that with improving knowledge and indeed the emergence of other novel devices, we're going to see a clearer role for the indication of percutaneous therapy, and we may see expanding indications. That's yet to be seen. Thank you.
Thank you, Manta. Any questions from the floor? Can I ask something of you? Can I have a show of hands of people that are working in units where MitraClip is actually being performed? Can I now have a show of hands of people that are working in those units where MitraClip is commissioned? That's the biggest problem. Just yourself, yeah.
Okay.
That is going to be our biggest challenge at the moment. So how have you managed to get